Hello, my name is Lasana Kamara, and the topic of my discussion is medication error within the anesthesiology department. My research is about a survey that was done to understand the level of medication error that happened within the anesthesiology department in Ireland. The survey covered both resident and attending anesthesiology. Medication error are often a preventable event. It can occur in prescribing distributions and administration of medications. This failure, which can increase the mortality and mobility of patients under hospital care, are commonly associated with the lack of professional communications and the collaboration in anesthesiology department. The work of the anesthesiologist is a delegate one. They prescribe, they make on medication, and also administer medication during surgical procedures. Unfortunately, although this error occur frequently, many of the negative patient safety outcomes go unreported by nurses who fear the response of the administrators and the disagreements about what constitutes an error or why it occurs and the consequence for their actions. The key information on the studies. Again, medications error go unreported because healthcare providers are afraid that they may be disciplined for their mistakes. As a result, the true magnitude of the problem is actually unknown. In all likelihood, many more medical errors occur, but only a fraction of them are reported. Why it is difficult to know the degree that healthcare provider might under-disclose. This survey can give an insight of medications error. Medications error disclosure is important because it provides the learning opportunity to learn from the mistakes. Provider face an ethical dilemma of whether to report medications error or not. The case study. This presentation talks about a study that examined the perspective of anesthesiology relevant to error disclosures. So this study was conducted using a cross-sectional method, a clinical Venn-based survey of anesthesiology to determine the accuracy with which anesthesiology can identify error, near misses, and the potential for harms where an error or near miss has occurred. A comparison was made to independent consensus rating the likelihood of anesthesiology to disclose error to patients or report error on their hospital reporting system was explored. The extent of the prior medication safety training was compared between anesthesiology and graded and correlated with error identifications and harm severity assessment. An online survey was presented to all attending and resident anesthesiology, a population of approximately 700 anesthesiology. Unfortunately, only 89 anesthesiology took part within the survey. The survey responses were anonymous to reduce non-response biases. Anesthesiology was sent a link to the survey via an email from their professional body, the College of Anesthesiology of Ireland, requesting their volunteer participation with periodic reminder for 2 months. This study actually lasted for 2 months. Anonymous survey was hosted securely on research electronic data captures called RECAP. Participants read an information sheet and complete the informed consent form before progressing to the survey itself. So every members that took part in the survey actually have to sign informed consent, which is very important. The method that was used in the study. Advantages were developed using the modified E-Duffy method by a consensus committee of 2 anesthesiologists with a particular interest in medications error, a clinical pharmacist specializing as a hospital medical safety officer, and a clinical psychologist who teaches patient safety at the Royal College of Surgeons in Ireland. This method had been recommended for use within the healthcare setting. It has a reliable means of determining a consensus for defined clinical problem. An initial set of 20 VANET were distributed to the consensus committee in 3 sequential rounds for review, comment, and modifications. The process focused on achieving consensus on the type of error, near miss, no error, and the potential harm severity, mild, moderate, and severe. During the E-Duffy consensus phase of the study, the committee was not asked about the requirement to submit an incident report or disclosures. The result: 89 survey responses were completed, and return of those 48, which is 54% respondents identify as an anesthesiology residents, and 41, which is 46.1%, was identified as an attending anesthesiology. The survey captures approximately 12% of all attending anesthesiology and 10% of all resident anesthesiology in their jurisdictions. The responses were recorded from 14 different acute care hospitals, providing broad representative samples. Overall, 23 of the 89 anesthesiologists reported having received medication safety training. Of those, more anesthesiology residents reported receiving training compared with anesthesiology attendants, although this difference was not statistically significance. Of the 23 who had received prior trainings in medication safety, 15, which is 65.2%, recall face-to-face training. 5, which is 21.7%, received online training, and 3, which is 13%, received written manual. The proportion of the training delivery method did not differ significantly between residents and attendants, suggesting that the mode of delivery where a curriculum exists did not change over time. The result. This slide shows responses related to VANET 1 through 4. The two near-miss scenarios, V1 and V2, were associated with a high degree of variability in response and a very low level of agreement with the consensus committee. Only 8% of the residents, 2% of the attendants, and 12% of the residents and 10% of the attendants, respectively. Although error awareness correlated positively with the harm severity assessment across all VANET, the effect size was poor to moderate for VANET 1 to 6. The case studies conclusions. Just 35.6% of the anesthesiologists recall having had medication safety training, which is kind of low. Many anesthesiologists fail to recognize an error or underestimate the level of harm resulting from such an error. A self-reporting rate of incidents reportings and error disclosure fall short of the standard. An extensive education program is required to raise the awareness of errors and embed appropriate reportings and disclosed behavior. The study also highlights the need for culture change within the healthcare institutions to improve open disclosures and reporting. Relevant articles and future directions for medications error. To identify strategies to improve medications error reporting, explore a variety of VANET to optimize training, and also to examine how and why healthcare providers calculate severity of medications error. Also to conduct similar studies for other types of healthcare providers, that is non-anesthesiologists, so at least other kinds of healthcare provider can understand the work of the anesthesiologist, and also to investigate how healthcare organizations should structure error disclosure policy to encourage reporting while at the same time prevent future error. Review of the literature, especially any outside analysis of the study. The research indicates that although most indication although most medications errors are harmless, some can have severe consequences for a patient. A study indicates that most anesthesiologists admit to having made at least one serious error in their career. The true incidence of medication error is unknown because, of course, most of the errors are not reported. Reporting of medication error is crucial to prevent future errors from occurring. My personal analysis of this study. This study does not provide any new information. It has been known all along that many medications errors are not reported. The proposal for mandatory training for error disclosures as a prerequisite for certification is excessive and harmful. It creates impression that the study was done solely for the purpose of justifying such training. There are other research topics that have greater priority. It is unfortunate that the authors decided to squander their talents on this problem. These are my references. If you have any comment or suggestions, please do not hesitate to reach me. I want to take this time to thank every member of the class for being with you guys for the past 3 months. I also want to thank our wonderful professors for his times. Whenever I email or call him, he responded right away. And thank you so much.